Our multidisciplinary group here at UCSD would like to thank SAGES and the selection committee for allowing us to present our work on salvage esophagectomies today. It's not always too late, a case for minimally invasive salvage esophagectomy. I have no disclosures. Current standard of care for locally advanced esophageal carcinoma includes neoadjuvant chemoradiation, followed by surgical resection 4 to 8 weeks after completion of this therapy. It's recommended that esophagectomy occur no greater than 90 days after neoadjuvant. Many patients fall outside of this window and eventually undergo salvage esophagectomy for a multitude of reasons. They may also have recurrent or persistent disease after definitive chemoradiation and require subsequent esophagectomy. Two definitions have been established for salvage esophagectomy according to the current literature. One is resection for recurrent or persistent disease after definitive chemoradiation therapy, and the other is any esophagectomy performed outside the 90-day window after completion of CRT. Salvage esophagectomy is perceived as a highly morbid procedure that has been associated with increased infectious complications, length of stay, mortality, and decreased overall survival in some studies. However, most of these studies were conducted in cohorts of patients with squamous cell carcinoma. The objective of our study is to assess the outcomes and survival of patients undergoing minimally invasive salvage esophagectomy as compared to patients receiving current standard of care treatment for esophageal malignancy. A retrospective review of a prospectively maintained database identified patients who underwent esophagectomy from 2009 to 2019. Patient data, including demographics, end date of CRT, and tumor staging and information were collected. Recorded outcomes included post-operative complications, length of stay, pathologic outcomes, and survival. Statistical analysis was conducted using the tests and models listed below. All tests were two-sided and the level of significance was set at 0.05. A total of 97 patients who underwent esophageal resection for cancer after CRT were identified. Patients were 90% male with a mean age of 65 years. 95% of patients had adenocarcinoma. The majority of patients underwent transhiatal esophagectomies. Two separate analyses were performed on the entire cohort of 97 patients based on the two literature established definitions. Analysis 1 defined salvage esophagectomy as procedures occurring after intended definitive chemoradiation for recurrent or persistent disease. This was compared to esophagectomy as part of planned trimodality therapy. This is the more classical definition of salvage esophagectomy and has been extensively studied for squamous cell carcinoma, less so for adenocarcinoma. Analysis 2 defined salvage esophagectomy as any procedure occurring greater than the recommended time frame, which was 90 days after completion of CRT. These were compared to those occurring within that time window. This definition is based on the notion that a greater interval between CRT and surgery increases the chances of recurrence or progression. Analysis 1, which defines salvage as surgeries for those with persistent or recurrent disease after DCRT, had 10 salvage and 87 planned patients. Average age and ASA scores were significantly higher for the salvage group. No significant differences were observed in any of the demographics listed, including preoperative staging and tumor histology. Mean time to esophagectomy was 89 days for the planned group and 532 days for the salvage group. There was no difference between salvage and planned esophagectomy in terms of pathologic results, 30-day complication rates, including anastomotic leak, length of stay, and 30-day mortality. Kaplan-Meier analyses showed that there was no difference in overall or disease-free survival between the planned and salvage groups, with 5-year survival rates of 46.4% and 40% respectively. Next, we move to analysis 2. This second analysis defines salvage esophagectomies as delayed procedures occurring greater than 90 days after completion of CRT. There were 35 patients in the salvage group and 62 patients in the planned group. Salvage patients were significantly older, However, there was no additional differences in preoperative data between the two groups, including ASA and preoperative staging. Average time to surgery after CRT was 63 days for the planned group and 261 days for the salvage group. Reasons for delay are listed below. Postoperative outcomes for analysis 2 were not statistically different apart from recurrence location. There was no difference in tumor pathology, extent of resection, postoperative morbidity, or length of stay. Though absolute recurrence numbers were statistically equal, there was a significant difference in the rate of local versus distant recurrence. 64% of the salvage recurrences were local as compared to 25% of recurrences in the planned group. That being said, the disease-free and overall survival rates did not differ significantly between the two groups in analysis 2. A Cox proportional hazard regression for disease-free survival showed no significant factors influencing this outcome, including salvage status. A Cox regression for predictors of overall survival was also performed. Advanced age, defined as greater than 75 years, significantly increased the odds of death with a hazard ratio of greater than 3. Salvage esophagectomy by either definition did not have a significant effect on overall survival. Our study is significant in that it showed no difference between salvage and planned esophagectomy with regards to disease-free and overall survival. There was no differences in the major secondary outcomes like morbidity, length of stay, and leak rate. These findings add much needed evidence to support salvage esophagectomy for adenocarcinoma. We believe our results reaffirm that this is a worthwhile and safe procedure for select patients suffering from esophageal cancer. Thank you for your time.